U.S. Conference of Mayors for inviting UNICEF here today. For those of you who recognize my face or voice from the years that I served at the White House when Jerry, Rohan, or I would call you to ask you to do a challenge, hello again. I promise this is not another challenge, although we do have some that are still living on that many of you contributed your time to, and I'm happy to speak about that later on. But the reason I'm here today is on behalf of UNICEF and is equally important. Most of you have worked with UNICEF before and have helped them reach staggering success in their mission to achieve sustainable change for children at scale. Or you've worked with the over 30,000 UNICEF Club members in high schools and colleges in your cities, not to mention the UNICEF volunteers from Rotary clubs and Kiwanis clubs in your cities as well. Now more than ever, UNICEF wants to make sure we are focusing on putting children first. And UNICEF and all the UNICEF members across the country are looking to mayors to help them in amplifying and supporting World Children's Day on November 20th this year. The theme of World Children's Day this year is #KidsTakeover, where kids are taking over high visibility roles to shine a spotlight on the most pressing challenges faced by their generation. We already have a number of celebrities and a number of ambassadors in companies like Target, Google, the NBA, Major League Soccer, who are planning to help support and lift up World Children's Day. But we wanted to make sure mayors were invited to play a key role as leaders in their cities, particularly as leaders in other countries are planning to get involved on November 20th as well. So what does UNICEF mean by supporting? On November 20th, we're asking if each of you could take the lead in hosting an event, a social media takeover for an hour or a full day, host a Kid Power Run, partner with a UNICEF ambassador or a partner corporation in your city, or just coordinate with a UNICEF campus club or UNICEF Kid Power classroom in your city and put the focus on kids in your cities and kids around the world. UNICEF will make it easy for all of you. There's a piece of paper in the UNICEF packet in front of you that has a request to put down the name of a POC in your city, and we will reach out to them with a connection to a local UNICEF club or child who can be involved in the takeover on World Children's Day. We can send a list of possible tactics, assets, and guides for World Children's Day, and a list of leaders in your community and your business community who are already planning to support and engage. The other option is we have a card for our point of contact at UNICEF, Danielle Goldberg, who is looking forward to working with all of you. And I want to thank you on behalf of UNICEF and myself for already putting children first in your communities, and we're both looking forward to working with your teams again in November. So on that note, thank you, Mayor. I'll turn it back to you.
Thank you, Alex. Okay, so now we're going to embark on a conversation that's been on the topic of many of our minds over the last few months, healthcare. Since Mayor Landrieu took over as president, you know, we've all been working nonstop before that, but certainly since that, to make sure our mayors' voices are heard on this very important issue. We called on all of our mayors to be very active locally, and our colleagues answered the call, and we thank you. I mean, as we all witnessed in a rather dramatic fashion, the congressional attempts to repeal the Affordable Care Act ended with an early morning no vote from Arizona Senator John McCain, who joined his colleagues, Maine Senator Susan Collins, and Alaska Senator Lisa Murkowski, along with the Democrats, to help reject the Senate's latest attempt to pass a repeal without a true replacement. And we want to thank our lead mayors on that effort, Mayor Marty Walsh of Boston for his team and their hard work, and Mayor Bill de Blasio of New York City. I thought I saw somewhere in the crowd, Charlene McRae. Are you back there? All right. The work that has gone on in New York City, not just around health care, but the work that Charlene McRae has done on opioids and substance use disorder, I think can't go without mentioning it as well. Charlene, you back there? I think I see you way in the very back. Would you stand up for a second and wave your hand? and thank you for your leadership on this. And as we was thinking about you, I didn't know you were in the room when we were talking about opioids, but as we have this larger discussion around healthcare, hopefully we'll have the benefit of having your voice in this discussion as well. Today we have, of course, Mesa, Arizona, Mayor John Giles, Bangor, Maine, Mayor Joseph Baldacci, and Anchorage Mayor Ethan Berkowitz. They were all very active locally with their mayors in their states, urging the senators to vote no on this harmful legislation. It was truly a team effort. There's still a whole lot more to do. Our national debate on health care is certainly going to continue, and hopefully our leaders in Congress will begin to work together across party lines to find real fixes to the Affordable Care Act to work to improve our country's health care system. And as we move through this ongoing debate, we must stay vigilant and continue to advocate for the policy proposals that make the most sense for all of our communities. To help us understand the ever-changing debate around health care, we have two outstanding leaders on health care policy with us here today. We have Bill Hoagland, who's the Senior Vice President of the Bipartisan Policy Center. At BPC, he helps direct and manage fiscal, health, and economic policy analyses. Bill's a former Republican staff director for the Senate Budget Committee and former VP of Public Policy for Cigna Corporation. He's been referred to as a bottom liner who's not a hard liner. We also have Karen DeSalvo. Dr. DeSalvo is a longtime colleague and friend of Mayor Landrieu's. She served as the acting assistant Secretary for Health and the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services until January of this year. However, most important is that prior to joining HHS, she served as the City of New Orleans Health Commissioner from 2011 to 2014. We also have, of course, Mayor Giles and Louisville Mayor Greg Fisher joining us in this conversation. And I'm going to ask the subject matter experts to start by asking you both to make opening remarks reflecting on the current state of play for healthcare legislation, and also to espouse in the areas where you think the mayors could have a strong impact either federally or locally. So, Bill, let's start with you.
Okay. Thank you, Mr. Mayor. I appreciate the opportunity to be here with you this afternoon. I'll be brief and to the point. First of all, just to lay the groundwork, I do work for something called, if you can believe it, in Washington, the Bipartisan Policy Center, and it was established 10 years ago by 4 former majority leaders of the United States Senate, Senator Bob Dole, Senator Howard Baker, Senator George Mitchell, and Senator Tom Daschle, and we're working as best we can to find some of these solutions to some of these difficult issues that you've been talking about here. A healthcare update. Let me try to give you somewhat, at least what my perception would be, some good news on the good news front, about 5 points. First one on what I know you had a discussion this morning about opioids. The President's declaration yesterday of opioids as being a national emergency. I know as Mayor Emanuel is leaving, he will remember this issue, that if the President declares it an emergency, Congress agrees it's an emergency, then funding for opioids is not subject to the budget rules and does not worry, you don't have to worry about offsetting it, as always is the case, to not add to the deficit. So that, I think, is an important factor, positive. On Medicaid, proposals that have been debated throughout this last few months on changes to Medicaid, capping Medicaid, per capita caps, all that. Quite frankly, Medicaid is off the table from my perspective, at least for the time being, and we can come back to that. The third point here is that the current law, the Affordable Care Act, is the law of the land. It is there today. It is as it has been and will continue on, though there are issues. I will also, number 3, give you credit too, along with those 3 very courageous Republican senators. I think you did have a major impact in terms of the defeat of the skinny bill that in Congress at the end. And out of that has come some green shoots of bipartisanship, if you like. Lately there's been something called the Problem Solvers Caucus in the House, 40 House members, 20 Republicans, 20 Democrats have put forth some immediate type solutions. There's a group called Convergence Group that was just this last week issued some proposals as it relates to an immediate fix. And most importantly, Senator Lamar Alexander, who I know many of you met with, and Senator Murray, they are scheduling and will have hearings early in September, and I think they are trying their best to find some solutions to this going forth. And then finally, I think you should know that the CHIP reauthorization will take place. Its authorization ends in September, into September. There is bipartisan support to continue that program, which serves about 9 million children out there. Now, maybe not on the not so good front. On the issue of the CSRs, the cost-sharing reduction subsidies, the next payment of those subsidies to stabilize markets is due 10 days from today, August the 21st. The President has the authority and has been taking the authority. This is the issue that's been challenged in court as to whether they should continue those subsidies or not. It is unclear at this moment whether he will continue those subsidies on a month-to-month basis, and that in and of itself creates a lot of uncertainty out there, particularly for the markets. Also, on the challenging side is that we don't have a lot of time. When the House comes back and the Senate comes back after Labor Day, if you can believe it, the House is supposed to be in only for 12 days, and the Senate in 17 days. I really don't see how that works, but that before we have the new fiscal year. And so in that time frame, in that very short time frame, there is some very pressing issues that have to be addressed. And that begins, number one, with funding government, just keeping government funded come October 1st. Right now, my perception is, having gone through this a few times, as others have around the table here, it does seem to me that we're probably looking at something called a continuing resolution, funding at current levels going forward until that's resolved. That's tough. However, the tougher and more challenging issue is the statutory debt limit. I have to remind all of you, we have a law on the books that sets the total amount that we can borrow at any one time. We will reach that cap sometime around the 1st of October. The confluence of both the continuing resolution, October 1st, and a debt limit increase, I've never seen that happen in my career, 40-some years in working in this world. That is going to be a very difficult situation. They also will need to do the CHIP reauthorization within that short time frame. So all of that is going forward. Then we have the uncertainty of the administration actions. We know the President has said, let it implode. He does have the three most common words, as I recall, in the Affordable Care Act was the Secretary shall. The Secretary shall. A lot of discretion. And in that regard, we've already seen it being applied to outreach, narrowing in on outreach, shortening the sign-up period. We've seen it, as I said already, on the CSRs, and maybe not enforcing the individual mandate. So given the limited time, the political feasibility, what can or could be done, working behind the scenes, plus I think you can help out on this, I think there is opportunity to do something. Now, it's going to be narrow. The first thing is Congress needs to take the lead and step forward and fund those cost-sharing reduction subsidies for at least for the next 2 years. We are to narrow that down and provide some stability in the individual market. We also need to do something on outreach, grants to states to expand outreach. You have a big role, I think, as individuals in your communities and mayors in your communities to actually help in the outreach effort, because we have a short-term sign-up period that begins on November the 1st, particularly if the administration is shorting on some of its funding for outreach. I am a Republican. You do have to balance this through a Republican Congress. So I would suggest that combining those two issues with the issue of expanding what we call section, I get into the weeds here, section 1332. It was put in the law in a bipartisan manner by the late Senator Bob Bennett from Utah and Ron Wyden of Washington, right? Oregon, I apologize, Oregon, right. And that provides greater state flexibility down to the local level and implementation. That is something which I think Republicans will support along with Democrats, the combination of that. And then finally, extension of the health insurance tax moratorium. We've met with a number of experts in this area, and they suggest that to just give us 2 more years on that tax moratorium. That, by the way, adds up to maybe in the short term a $40 billion package. It would have to be offset, and there are offsets that can be done, particularly as it relates to Medicare Advantage. So what can mayors do? First of all, please help on this. Do not let government shut down, and certainly do not default on our debt. It will impact your finance more than anything else that I can think of. Your municipal bond, the ratings, the treasury bills, this has never happened in the history of this country, but I swear I'm hearing people say, let the country default. I can't believe Republicans, as a Republican, controlling the White House and the Senate, would ever let that happen. But that's Washington right now. As I said, you were successful. You did have an impact along with those 3 GOP senators and other groups against the skinny bill. You have power there. Place that into place as it takes these minimal changes to stabilize the market in the short term. That we can do, I think, in a bipartisan way and get something done quickly. In the near term, obviously, the usual. Your senators, your governors, your representatives, focus on this prevention issue and opioids. Remind them, some of them will not even remember the rules, that they do not have to offset this now that the president has declared it an emergency. And then outreach, outreach, outreach. That, to me, is the biggest issue you can help us with in the short term, is to get participation, get the sign-up going. That's critical to maintaining and stabilizing the market in the short term. With that, I'll turn it over to Karen.
Awesome. Thank you. Karen.
Great. Well, thank you all for the opportunity to be here. And I just want to make a quick note to say that it's nice to put some faces with some names. When I was at HHS, one of the opportunities that I had was to learn a lot about what cities and local communities were doing to advance health in collaborative fashion. And many of your communities are ones that came up on the radar. It was some work we called Public Health 3.0. I want to mention that sort of again towards the end. I thought what I might do is to complement what Bill has shared, talk about what is likely to happen whether or not ACA remains the law of the land, what the trends have been in the country, and what opportunities are in hand within the administration, particularly within HHS. Four key areas I wanted to highlight, and then maybe 4 specific suggestions about things that you all can do using the levers that you had. I think the first comment I wanted to make is about just the ACA in general and what is likely to happen, and we're seeing it unfold, and that is that the law requires a lot of care, watering, and feeding. It's like the most delicate plant that you could ever have, and the time that the Secretary of HHS or others spend on nudging, nuancing, supporting areas where there are gaps, counties that are losing coverage is quite intense. And so I think want to make sure you all are aware that even in the absence of statutory action, there's quite a lot that can be done by the administration to really kill the actions of the bill, the good actions of the bill, just by inaction, and it doesn't necessarily need to be action. I think one of those areas relates to enrollment, and though there have been some funds that were applied to local communities to help support enrollment, and that made certainly a big difference, there was also an effort on the part of the administration that was pretty intense to leverage the federally qualified health centers, to leverage the social services programs, to leverage the Indian Health Service to really reach to the ground. And in the absence of doing that, a lot of people are going to lose support and information about the enrollment period and the opportunities that they would still have, not only for the individual marketplace, but potentially also for Medicaid. Outside of just the marketplace and the coverage is the Medicaid piece, which is something that, even though legislatively may be off the table, although I haven't let out my breath on that yet, because I still think that in the near term, I think that there's still an eye on an opportunity to modernize the rules of Medicaid and maybe reduce mandatory spending. So there's some good and some bad in that. But even within the opportunities that the Secretary and the head of CMS, Center for Medicare and Medicaid Services, have right now, there's a significant amount of flexibility in the statute. And I think you're going to see not only flexibility in rapid approval of waivers, but also some consideration of things like partial waivers, so not requiring maybe the full extent of coverage that some states have given to their populations, and then also some expectations on the part of the beneficiaries. So whether that's about work or cost sharing, or whether that's around premiums or even co-payments for emergency departments. And so there's some, I think, probably realistic chance that your states are going to be wanting to adjust their Medicaid programs, and that they're going to find a really willing partner at CMS, and that, frankly, that partner has a lot of latitude. The third area I wanted to mention, Bill mentioned, and this one often gets lost. This is the 1332 provision in the Affordable Care Act, which is in and of itself a pretty powerful tool to set the state's own expectations around what the marketplace looks like. So defining essential benefits, deciding co-pays, just as examples, and that stands to touch not just the people on the individual market, but there's potential that those changes could be more broad. And the Obama administration regulations were stiff, as people would say, and didn't give as much latitude, but there's an opportunity for some rulemaking in that area, and again, for some rapid approvals in the 1332 space. I would say also, my understanding is that the HELP Committee and others are interested in understanding if they could even push the 1332 further, so that kind of a waiver for the marketplace could also work in better partnership with waivers maybe for the Medicaid program. So it's something to watch, because it could stand to change the insurance marketplace a lot, and it could be an opportunity, but it really could be a significant problem if it's not carried forward well. And the last thing that I wanted to mention is about just cost reduction, which maybe not the thing that is always on the top of everyone's mind in this big debate about coverage and getting more people into the tent and getting them covered. But the reality is that most of us would say that there's enough money in the system, and that what we haven't done well is apply it appropriately, whether it's because we're not giving people enough access to really quality primary care, or addressing some of their social needs like access to healthy food, or access to the kinds of social supports that many of your cities provide for them. And the effort around taking cost or waste out of the system has been ongoing. It was certainly supported by the Affordable Care Act, and it doesn't seem that it's going to stop, certainly in the private sector. The states are keenly interested in this through their Medicaid programs, and again, could be great if we cut with a scalpel rather than an axe, but just lopping off a bunch of budget without really being thoughtful of where we have opportunities to make the system more efficient and serve people better would be a disservice to them. On the other hand, communities that are taking matters into their own hands by creating local coordinating organizations that are bringing together the healthcare sector, public health, social services. There are some structured models like in Oregon, Washington State, New York, Massachusetts, that are gathering some, I think, really important lessons learned and data. But that kind of movement, I suspect, could be a really exciting opportunity for local, for municipalities going forward. Again, needs to be really thought of not just as a healthcare intervention, but really a broader health intervention. And given that many of you all offer social services and/or have a hand in running WIC programs, et cetera, I think it's really important that you're part of that solution at the table. So just the four quick things that overlap, thank goodness, with Bill in some ways, is that one is about enrollment. I think this was inserted into my DNA when I was at HHS, that we have to get people excited about the enrollment period. So, but on the other hand, all of our shouting from Washington doesn't mean much. Where the rubber meets the road is in your federally qualified health centers, in your libraries, in any other place like a WIC clinic, where you're touching people on the front lines and they have a relationship with someone who can really help them navigate those scary questions and the terminology that is so off-putting. So it's using your bully pulpit, but also leveraging your workforce who is in touch with the populace every single day and whom they trust. The second is about your shared voice. It was mentioned especially on the CSR, but other areas. What this country needs now more than anything is shared leadership, shared voice, that people can find common ground that just makes sense. The third area is, again, to really pay attention to what your states are thinking about, even in the absence of changes on the Hill, about changing their Medicaid programs or leveraging these 1332 waivers. A lot of your states are in the midst of that. And it's a conversation you and your team should be involved in, again, because some of that just runs downhill, and you're going to be taking care of folks who got left out of that conversation. And then I think finally is just to encourage more of this movement I'm seeing that I call Public Health 3.0, but there's other language which is really about communities working together to create the conditions in which everyone can be healthy, and that's leveraging the best of healthcare, public health, civic society, and technology. And I know some of y'all are engaged in it, but to me that local solution is how we're going to keep momentum and get the conversation to shift away from partisan squabbling, yelling, fighting to real action for people on the front lines. Thank you.
Perfect nexus, having a Republican mayor and a Democratic mayor talk about ways in which they've been doing work in a bipartisan, a nonpartisan way to advance the interests of the people in their cities and our country. First, go to Mayor Giles.
Thank you very much. And can I just say how proud I am and grateful for this organization? The last few weeks, as we went through this process of lobbying our senators, to me really demonstrated the great need and the great value of this organization. I appreciate the leadership that was demonstrated here. In particular, Mayor de Blasio, First Lady McRae. We had weekly telephone conferences asking about the status of those states that had particular senators that were in strategic locations, and I know that had an impact. I'm very proud of the vote of Senator McCain, and he was the first to acknowledge before, during, and after that vote that his vote was informed and impacted by local elected officials telling him how that was going to impact their communities. So to me, it's just, it was a great kumbaya moment for this organization and a great reminder that we can have impact, that there's not such a partisan divide that will have a negative impact if we don't allow it to. And then Senator McCain's comments, if you might recall, they were less about health care and more about bipartisanship. And I think that's a very inspiring thing as well. So I'm delighted to hear from Bill and for us to hear more from Bill about what we can do going forward on this. Clearly, our job is not done. The next issue, the next crisis that we have to deal with on health care is stabilizing the individual markets. I think Bill did a great job of describing what the next action items are, but I think we need to take the same enthusiasm, the same organization and commitment to lobbying our senators and congressmen to the next level of this problem, so that we can continue to see good success and to protect our communities. So having said that, I know I was delighted to be with Mayor Fisher in Washington just a couple of weeks ago, and I think he made the comment that he sensed a change in people's attitudes. That you may recall when we were there in March, there was very much a partisan atmosphere, but I think the events of the last few weeks in D.C. have really inspired people to realize that they need to find a different way to respond to the problems that our countries face. So I'm more optimistic than I have been in a long time after having witnessed the events of the last few weeks.
Thank you, Mayor. So to me, and Dr. DeSilva focused on this, the key issue is cost. As a country, we're spending 18% of our GDP on health care. The United Kingdom delivers universal care for 8% of its GDP. Germany is at 10%, and again, they're covering everybody. So until we take a look at our systems redesign and focus on wellness issues and get away from our current reimbursement of fee-for-service, we're not going to be optimizing our healthcare system in total. So it's interesting to me, and I would encourage everybody in this room to challenge Washington to, while we're in this kind of partisan divide sometimes on who should get what at what price. The real issue is getting our 18% down to 14% or 12%. And when we do that, other countries can do it. We need to kind of disregard this American exceptionalism that we can't learn from other countries. We can cover more people if we redesign the system, and we can have money left over to pay down the debt or to contribute to infrastructure. And I just don't think there's enough discussion around that. I'd like, after I say one other thing, to have Bill and Karen comment on that issue. To me, that is the big issue, and you're just not hearing as much talk about it. Let's put our energy into getting our cost out of the system and make that type of bold reform. I'd also like for our speakers to comment on the role of innovation in this at the local level. You're seeing more and more cities harness their citizens as sensors, if you will. In Louisville, we have 1,200 citizen scientists, also known as volunteers, that we've equipped their asthma rescue inhalers with the GPS device so we know when and where they're using their device. So we constructed a heat map of the city on where these episodes take place so we can make macro interventions on traffic pattern changes, introducing vegetative medicine, also known as trees and shrubs, which we're proving through samples of school children and administration to lower the toxins in their blood system. And we're able to do that by pulling all of our commons together to give us this kind of information. Then we're doing individual interventions with a respiratory therapist when we find someone's using their inhaler way above the norm. And we've seen decreases in the use of inhalers by asthma patients of 72% and COPD patients by 62%. So we're harnessing the ability of the web, big data, and an individualized response to increase health and decrease the cost of health care and build trust between people and between people and institutions. So to the extent that you all see innovations like this taking place around the country and how our cities can be urban laboratories for that to help inform cost reduction and innovation, be curious to hear what our speakers have to say on that.
Well, Mayor, I may pick up on that thread and first of all, just share that there are some key components to getting that kind of work done, and the first of which is leadership. And what's I think important for you all to remember is how you all can serve as a neutral convener to the healthcare system in a community, because you typically are not running healthcare services. So it allows you to bring folks to the table and start to ask those harder questions about how can we reduce costs together, what's our shared goal, and also ask that hard question of will you be willing to share data, because many times they don't want to share data that allows you to take targeted action across the board, but there are some really fine examples of how that is happening on a more ad hoc basis. I always use Nashville as an example, and in that case, Bill Frist, along with the mayor and the local public health official and the Chamber of Commerce, have really built a nice infrastructure, but that has been replicated in every time zone and every temperate zone that I've seen in this country, and they evolve into serious action. And sometimes though, they move towards wanting to get a Medicaid waiver or a broader waiver that allows them to blend funding from Medicaid, SNAP, housing to really tackle important challenges, whether that's opioids or childhood development. The flip of that is sometimes the Medicaid program can cause that to happen, and that's more of the example, I think, in places like Oregon, though they had a fertile field, where the structure of that program is to bring collaboratives together. And a lot of the focus in those efforts, as you say, is not just about what's happening to somebody when they're in the healthcare system and how do we make sure that we're being as efficient as possible. They're really thinking about this idea that health is more than healthcare, and where we live, learn, work, and play really matters. The kind of food you eat, the food you have access to, the transportation, the housing, the public safety, these social determinants. And the healthcare system alone is not going to be able to address those issues. That's where I think the mayors are a great partner. And it's not just like a lofty idea. I just have to say this. When you dig into the data about cost in the U.S. and the cost in the healthcare system, about 5% of people spend about 50% of the funds. And if you look at those individuals, particularly when you start to look at those on public systems like Medicare and Medicaid, they're not just medically challenged, have a lot of chronic conditions, they have a lot of social needs. They're going to bed hungry, they don't have social networks, they don't have transportation. And so it's not just a nice idea to want to address the social determinants, it matters to the bottom line and also to their health outcomes. And there's an accumulating amount of evidence that it's just good, if it's good business, could I say it that way, to really think more holistically about people's health. And again, the healthcare system can't do it alone. I think I'm very excited at these kind of collaboratives that are tackling it.
In the words of someone who knew healthcare could be so complicated. But one thing, Mr. Mayor, I would say, and I just pick up on Secretary DeSalvo's comments. My last boss, Dr. Bill Frist, Majority Leader on the Republican side, likes to point out, he says that 80% of the cost of healthcare, and this has nothing to do with the doctors and the hospitals, it all has to do with the culture of health. And I think that's what we were referring to. So you have, we're talking about it, we're talking nutrition, we're talking about the environment, we're talking about housing, we're talking about the infrastructure, water. Those are the things that you have a major impact in influencing the cost of health care that you're worried about, Mr. Mayor, as it relates to going to 18%. I am not suggesting here today that we shouldn't be focusing on the cost of health care. I think that's right. I do think we have to change the whole delivery system that we have. And by the way, in the Affordable Care Act, it's always interesting to me, the larger portion of that Affordable Care Act had to do with changing the delivery system. You never hear about that as being, quote, repealed, alternative delivery systems. The movement away from fee-for-service to a more managed care, I think, will help you move in that direction. We should do that. All I'm suggesting, in the near term here, when they have to file by September, when plans have to file by September the 6th, their rates for 18, we can't change the delivery system in that time frame, and we have to focus on what we can do to stabilize the market here in the short term, or we are going to have problems. So I agree with you completely, but let's focus on what we can do quickly, fast, and have bipartisan. And also, let me say, I think you did the right thing, Mayor. You focused on the Senate. The House is not going. I think the House is not going to do anything until the Senate acts. And your best bet right now is exactly where you were with Senator Lamar Alexander and Senator Murray, because they do want to do something in the short term to fix the stabilization. And I'll play the old budgeteer with you. When you have must-do legislation called a continuing resolution or debt limit, you can certainly put those quick fixes on that and get it done and help stabilize the market in the short term.
Thank you. Got some questions for our panelists? Karen, I have a question for you. From your perspective, since you have both local and federal experience, when mayors hear that we need to stabilize the markets, what should we be concerned about?
I'm going to start and then I'm going to punt over to Bill. But so Bill's right that I'll start to play off of this, which is when people don't have access to an affordable health insurance product, they die. And that the through line for that data is not exactly direct, but there's enough anecdote and there's enough data to say that it matters to be covered, that it's a part of what your health outcomes are. But it has to be an affordable health insurance product. And the way that the Affordable Care Act changed the way that we receive insurance coverage in this country, maybe forever, maybe temporarily, is that it created pools and it gave a lot of backstop support to the insurance companies, so they were more willing to take on some risk. They were more willing to take on people who might have needs for services, might have more medical conditions, maybe a history of medical conditions, and not hold that against them, so they could get in the system and get the treatment that they needed. And the markets feel very destabilized. I'll try to speak for them because they're not sure what tomorrow is going to bring, meaning should they keep taking risk for people who have medical conditions that may become quite expensive for them and not be able to use the tools that they've been able to use to exclude people from coverage. I mean, they've got a business and they want to be able to, in some cases, demonstrate that they can turn a profit or at least have some reserves. And their business tools that they used to use to assure that, we changed with the ACA, and so now that's required some subsidy from the federal government and a fair amount of tinkering also where you might have some gaps in pockets. So it's kind of maybe the simpler way I would try to say it is we created a new marketplace and we're trying to learn how to regulate it, and so nobody's quite got that right yet, but what we do know is that when you don't try to do anything, it becomes quite unstable, and that translates not just into people losing coverage who are on the individual market, but it affects everybody's cost all across the board, and that's your employees, that's the people in your community. So it's instability is never good for business.
From a very straightforward perspective, Mayor, when I think of stabilization, I'm thinking about it in terms of the rates that are being charged. And I keep driving so hard that you should focus on these things called cost-sharing reduction subsidies that are tied up in the court and have been being paid off and on, is Blue Cross Blue Shield, if somebody from North Carolina will correct me here, Blue Cross Blue Shield of North Carolina is filing its rates to go into effect. They are filing two rates. One rate is if those payments are made, the increases will still be high, 8%, but without those payments, without those cost sharing, the rates will be 22%. If the rates are 22%, people will not purchase. They'll drop out, or the companies themselves will not provide. Then you do not have coverage. You do not have coverage, then where do those individuals go? They end up in the emergency room. That's the cost, and that's the stabilization I'm focusing on.
I want to just maybe make some more general comments, if I might, which is to say that there's a sort of a short, medium, and long game going on, and the short game is the markets need to be stabilized, and I really don't know anyone who doesn't agree with that. If you want to see that people still have coverage and you want to see that there's some certainty about the business model for the insurance industry, which is a huge part of our healthcare system. That attention, though, on that one piece of the conversation can be a distraction from some of the other things that both Bill and I mentioned, where vulnerable populations could be hurt or there could be opportunity for change, right? So if you spend a lot of time and energy thinking about the individual market and cost sharing, and we don't take the time to make sure that we're creating Medicaid programs that help lift people out of poverty, to create 1332 waivers that allow for some state flexibility, that in their own marketplaces, on the good, on the bad, maybe bad things happen. We miss an opportunity to do better by our citizens, right? So the sooner we get the market stabilized, then we can move on to having more meaningful conversations that are more in the intermediate game. The longer game, which people are engaged in, is this: how do you make the system more efficient and effective? How do you make it serve people the way you want your family served? How do you make it bring health to your community and not just gain wealth from your community, to be a little bit blunt about it? And so I think the mayors have a huge role to play in stabilizing in the short run, but at the same time, you've got to keep your eye focused on these longer term issues, because that's I think where the real opportunity is for you to bring health.
Yeah, so how do you all see this rolling out? I guess the shocking news too last week was a regular order by Senator Alexander and Senator Murray, where they're going to start some hearings, I guess, on some limited changes to the Affordable Care Act. So if you all had your crystal ball and could play this out over the next 1 to 3 or 4 years, however long you think it would take, what should we look to as the critical milestones, annual milestones, that you'd suggest that we rally around in terms of changes in the law?
I sound like a broken record, and I apologize, Mayor. I think that Senator Alexander and Senator Murray, Chairman Alexander, Ranking Member Murray, they want to do, first of all, appropriate this money that I've been talking about that's tied up in the courts on these costs. I think they want to do that, and I think we should support them strongly on that. There's always a question whether the president would veto that, but let's assume that that's number one in the short term. The second thing they want to do is exactly where I think recognizing reality, What Republicans want on Capitol Hill is greater flexibility. That's why this Section 1332 expansion. We had a little project, if you can believe it, at the Bipartisan Policy Center where we had Senator Daschle and Newt Gingrich agreeing that we should expand the usage of Section 1332, which gives you, the states, and the localities a greater flexibility in implementing at the local level where health care is really delivered. So I think in the long term, is to move in that direction of greater, more out of Washington back to the states and to the local levels. I also think, and I didn't want to dismiss, as a budgeteer, I can't dismiss the fact that Medicare costs us, Medicaid costs the federal government and costs you, just the federal side, $400 billion a year, and it's growing at close to about 5.5% annually. Medicaid is about $600 billion, so $1 billion a year in just those two programs at the federal level, and they're growing at almost 2 times the rate of growth of the economy. That is unsustainable. Now, part of that obviously has to do with demographics, but a lot of it has to do with where you were, Mr. Mayor. It has to do with the efficiency in the delivery system is driving up the per capita cost. So I think that we come back long term, besides dealing with those who need care, and that's in the Medicaid. Karen, Secretary Salvo said this, I'm not taking Medicaid off the table. I don't want to take Medicare off the table either. I think the two need to be addressed in the terms of long term. But we know, as you as elected officials know, those are extremely politically sensitive programs, and how you make changes in them that don't affect people, is very, very difficult. But I don't know. To answer your question, maybe I'm filibustering you, I think the bottom line is that the system is not sustainable as it is. We have to change the delivery system. These things that I've recommended are short-term, I admit, just to get us back to some form of stability. And by the way, if it turned out that actually a bipartisan solution was found, maybe that could spring into greater bipartisan solutions later on.
I just want to add a note of optimism also,
Thank
which
you.
is to say that for all the rancor, my experience in DC was that, especially when the HELP committee is involved, it's a very bipartisan, thoughtful environment. And what they were able to do, for example, with 21st Century Cures, along with Energy and Commerce, but there was some really, some nice conversation. It's a great set of staff who are really thoughtful. They become quite knowledgeable. So I have a lot of hope for what Murray and Alexander are going to do. I'm sorry, Mayor.
I was just going to add that when we were on the Hill a couple of weeks ago and Senator Alexander kind of tipped his hand that there was going to be a return to normal order and that they were going to have bipartisan hearings, he also kind of tempered that by saying it was going to be pretty modest in terms of what their expectations were to get out of that. They were only going to address 1 or 2 issues where there was kind of universal agreement on. And so I think it's good to remind ourselves that there are 2 things going on here. There's a short game, as has been described, in buoying the individual markets and not just sitting around watching them implode. But on the other hand, I think as mayors, we all need to realize that maybe it's going to be not this session, but next session, there hopefully will be an opportunity for us to walk in and say, let's start with a clean sheet of paper. Let's talk about, as Mayor Fisher mentioned earlier, how to actually lower the cost of health care, how to use some of the things that cities are doing in an innovative way to provide a better model rather than just continually putting Band-Aids on the problem.
As somewhat of a practitioner and a recovering Washingtonian, it's a 12-step program, Bill. You may want to try it once in a while. I actually thought, look, I think the president made a really dumb mistake by going into health care first. Totally, and I think you can see the end result of it. And they're not going to get out of this problem given his communication yesterday towards Senator McConnell. So I always thought that the best way to do this was come up with a short-term solution, because the Medicaid problem isn't the problem. It's actually the individual marketplace where they're now doing solutions. I have a thought about that at the end of this. But come up with your short kind of package things for stabilization. I would kind of throw KidCare into there, because the CHIP program, KidCare, that, because I think that actually brings votes rather than sends them away. Nobody wants to be, because I think nobody wants to have a vote kicking kids out of health care. With a specific time frame for dealing with the long-term set of solutions, that in the next 2 years, X, Y, and Z, and these are the principles, so they can actually get out of the quagmire and get to other issues, because I know the president doesn't look like he's going to let go of health care. I think the only way you're going to get the House to buy into what the Senate's doing is that there's some commitment to actually, they don't have their vote hang around them, that they voted for something and now they failed. So that's one. Two, I think on the long term, two things on long term. One is, I've always thought that it was a mistake to have individual state by state. You know, the federal government has 29 insurance companies competing. It's the largest healthcare exchange in the United States. It's actually the largest healthcare exchange in the world. And I don't understand why we would never say the healthcare exchange is the federal exchange. There's 29 insurance policies and programs in there, and everybody gets to buy into the same program that their congressman and senator have. And then you can turn the populism into a service that actually everybody gets the same exchange. You know, a federal worker in Montana buys the same kind of health care choices that a federal worker in the city of Chicago has. And it has nothing to do with rural, suburban, big population, small population, because it's an insurance exchange. And use the federal exchange as a way to eliminate these state-by-state models, and now you have an exchange that everybody has access to, that your congressman and senator have. It will require the subsidies, but therefore it's not about a Massachusetts exchange, Arizona exchange, and you get away from the chaos of 50 different models, et cetera. The other piece of the, so the one other thing I will say is, at Chicago, and I say this to us who have some capacity, I implemented across all our contracts a wellness plan. Now, my health care costs are still the same. This is not the only reason. They are the same today as they were in 2011. Well, health care costs have gone up 25% in the United States. So if there's 6 chronic illnesses: heart, blood pressure, diabetes, et cetera. You think about our public workers, they're not really reflective of the country as a whole. But on the 6 things, everybody has to go, including the mayor, goes for a checkup. If you have a problem with heart, you have a problem with weight, you have a problem with smoking, or you have 2 of those things, you have to show that you're making progress. If not, it's $50 more a month. All 38,000 employees are on a wellness plan in the city of Chicago. Police, fire, garbage truck, carpenters, electricians, mayor, everybody. And I actually think one of the most important pieces of health care, we as municipalities have an opportunity to lead on a big cost-saving initiative. And it's clear 8% of the workforce of the city of Chicago drives 62% of all our costs, around 6 illnesses they themselves manage. Not the doctor, not the hospital. Whether they eat, whether they smoke, whether they have a history of heart problems. So offer that as an idea where I think mayors themselves individually in your municipality can take a lead.
Any other comments or sharing or questions for our panelists? Dr. DeSalvo had to catch a flight, so excuse her absence. All right. All right. Well, thank you all so much. We're going to start our equitable development session in about 10 minutes. So you got a quick 10-minute break, and let's get right back at it. I know this is a session I really regret Mayor Landrieu couldn't be here for. I know he's excited about it. So we'll start up in about 10 minutes. Thank you.